It may contain scenes that may upset children under the age of 10. Parental guidance is advised.
Every year, 15,000 women die as a result of pregnancy and child-related issues in Kenya. The statistics are just staggering. 5 out of every 100 children will not reach their first birthday. And for this reason, Philips Healthcare Africa and KTN have brought together Saving Mother and Child to discuss the way forward. Welcome to the show. At my far right is Dr. Ann Kihara, a researcher on maternal and child health, the vice chair of the Kenya Obstetrics and Gynecology Society, as well as a consultant obstetrician and gynecologist at the University of Nairobi.
Welcome. Hello.
Next to her is Peter van den Ven. He's the general manager, Philips Healthcare Africa.
Hello and welcome.
And next to Peter is Lucy Mushiri. Lucy Mushiri is a certified nurse and midwife.
Hello and welcome.
And next to her is Dr. Yamal Patel. Dr. Yamal Patel is an obstetrician and gynecologist at the Aga Khan Hospital.
Hello and welcome.
And finally, we have Dr. Sharif Shanaz. He's the Director of Public Health at the Ministry of Public Health and Sanitation.
Welcome, everybody.
Now, we are talking about saving mother and child. Why are mothers dying, giving life? Dr. Ann Kihara, you have done a lot of research on this area. Why are mothers dying during childbirth?
There is what we call the delay system. Women not recognizing in the community that they need help, or having stumbling blocks even within that community where she knows she needs help, but possibly it's not being facilitated for her. Then we have the issue of how do I get to the facility? Access. We have variable geographical areas in this country, hilly terrain, roads that are not passable. That could be an added insult for her, with a problem trying to get there. And finally, at the service delivery point, does she get what she appropriately requires when she does get to the facility? It begs you to ask, is the infrastructure there? Is there personnel to deal with her problem? And if not, do we have referral mechanisms in place for her to get to the next stage, but at the same time, safely for herself and for her baby?
Lucy, as an independent midwife, how is your experience dealing with Kenyan mothers? Why are we losing some of these mothers during childbirth?
I want to very much agree with Dr. Kihara on the point that awareness is our biggest enemies. And I have worked even with educated women, so it goes across the board. From the rural woman to the urban woman, awareness is a big thing. And then when you know, if you know that you are supposed to go and access this care that is there and available to you, the kind of care you get at the point where you go is also wanting to some extent. The quality that there is needs probably some added bits to it to help sustain the woman's life at the end of the pregnancy and the child as well.
We have the Kenya Demographic and Health Survey, which shows, very shocking statistics. Less than half of Kenyan women are being attended to by skilled personnel. Why aren't they seeking the services of skilled personnel like yourself?
First, I think just to go back into history, and if you look at the Kenyan history, birth was not a situation that was one that you should go to hospital for. It's a normal natural process, and most of the times it used to happen at home, and you would get help from your auntie, from your elder sister, from a woman within the community who knew how to help women with birth. So I think that mentality still exists. And birth is still taken to a larger extent as a natural occurrence that doesn't need a lot of medical and technical support.
That is right, and we still do have a lot of traditional birth attendants. Although the ministry now is telling Kenyans, to move away from traditional birth attendants. Dr. Sharif, more than 50% of women are still giving birth using the services of traditional birth attendants. When the ministry then tells these women that they should go to hospital instead, they should seek the services of skilled personnel as well, what then is left for these traditional birth attendants in places where accessing healthcare is difficult?
Well, let me take up where Anne started off is the attitude. Actually, it may not be the attitude. It is issue of access. If you look at the demographic and health survey, you find these persistent inequalities. Certain parts of the country that actually achieved the MDGs, right? But certain parts have sort of stagnated where they were 5 years ago. So it is the inequities in the health system, in the infrastructure, which have persisted ever since we got independence. So part of the reason why we are not getting to where we should be in terms of the Millennium Development Goals is this inequities. So the minister's position is very simple, is that we are trying to make sure that everybody gets care under a skilled birth attendant. Because we tried out using traditional birth attendants in the 1990s. It did not actually improve the situation. So we went back to the system that everybody should be delivered by a skilled birth attendant.
Dr. Kihara, what percentage of obstetricians and gynecologists are out there, out of Nairobi, in the rural areas? How many do we have there?
I think it'll beg to ask, how many are we in the first place? We're about 500 in this country. What's the Kenyan population? 38 million. By the WHO standard, we should be having one gynecologist to about 10,000. So we already have a very big disparity. Secondly, whether we like it or not, there's economics of scale. And doctors tend to concentrate in urban areas as opposed to being in the rural area. We do have midwives, and we are beginning to now embrace the issue of having skilled personnel, including medical officers, clinical officers, sharing in this task to ensure that mothers and babies get the best possible.
Every time doctors are posted out of Nairobi to remote areas, talk of northeastern, to Wajir, they will go there just after their internships, and after a short period, they are asking for transfers back to Nairobi. At the end of the day, the doctors are not helping the situation. What do you think, Dr. Ari?
If a doctor is posted towards northeastern Kenya or something, and he is probably the only doctor around in the vicinity, and he is not having all the facilities that he needs to probably work with in terms of providing the necessary care for his mothers and the newborn. So he might at one point or another somehow get frustrated over it and then decide to ask for a transfer back to to an urban area. One of the ways that the ministry or the government should help is decentralize the facilities or of high order. Like if we have, when I say tertiary level care or those kind of centers should also be out of Nairobi, then you will find the doctors going to that place because they have a tertiary level center.
We only have 2 national hospitals in Kenya, but what about the rest? The distribution of the primary health care facilities, are they well equipped? What is government doing to ensure that these primary health care facilities do have facilities to do C-section, to do ultrasounds? Dr. Ari, what's your take on that?
I think it is not feasible for the time being to make sure that every rural health facility has, facilities for cesarean section. It is simply not possible. We have around 7,000 health facilities in this country. So the issue is to make sure that those who will deliver normally should be able to deliver in a basic setting of a health center or a dispensary. But those who have a complication should be referred to a district hospital where cesarean section or other things are possible.
We have managed to go to some of the far-flung facilities. They do not have working ambulances. Why can't we have the technology that we are talking about in those primary health care facilities as far as they are in Turkana, in Wajir, and in Kajiado?
It's nice to say that, yes, we need technology. it is going to help, right? But in reality, if you do not have human resources there, the technology is not going to work, right? So we have to find a situation where we actually keep human resources in those levels. Having a skilled birth attendant at a facility or even out at home will make all the difference. Putting technology, but at an appropriate place, maybe a district hospital where people can operate the technology. If you look at our staff distribution, right, around 59% of all our staff is actually working in an urban area. The others, and for others, it may be 80% of staff working in an urban area, and it's only 20% working in the rural area. So it's the skills which we are missing out there in the field.
Before we come back to that particular point and what government is doing to ensure there is equity, let's talk about technology. And of course, this is something that is really at the core of Philips Healthcare Africa. And perhaps, Peter, you can tell us, what is Philips' role in what we're talking about, saving mother and child?
Well, first of all, I believe that technology is really making a difference, specifically in early detection of complications. And I understand the challenges of the Kenyan healthcare infrastructure, but early detection of complications will also mean that you can take timely precautions to also arrange for the other areas, transportation, etc., to the facility where people can be helped. We, as a leader in the industry, we believe that we have two commitments. One is to bring affordable solutions to the market, which are easy to use and which are also easy to be trained on. And that is the second part where I believe that we have a responsibility to also connect to the supply of the equipment, the training of the healthcare workers that have to operate the equipment. Next to that, there is also the option to, from remote areas, transmit data to centers of excellence where the diagnosis can be set, and the mobile networks, etc., in Africa have been developed tremendously over the past years. So the network is there to transmit data, and the network is also there to provide back by means of a simple email or by means of an SMS or even a telephone call and advice on what needs to be done next.
Mm-hmm. Dr. Kihara, you looked very, excited when listening to Peter. What he has to say, does it resonate with what you're doing?
It certainly resonates with me. But I also want to look at things slightly different, especially in the context of our current constitution. I tend to think women have got thorough gains in this sense. Reproductive health has been keyed out as a most essential component, which tells us and begs me to actually look at our society. Without a woman, without a safe mother, without a safe baby, then we don't have a healthy Kenyan society. So technology would be needed, skilled attendants would be needed. But with devolution of health to the county levels, I think that will be the beginning of our gains, where we can actually utilize data generated from all the different parts of Kenya to actually see, in this particular county, what is the priority.
At this point, we would like to bring in our audience. How can we save mother and child in Kenya today?
Dr. Kihara, have you developed any guidelines for mothers so that for health workers as a professional body or as a university to be able to help, in the devolution, so that we have some guidelines that we can follow as medical professionals? And the equipment, Philips medical system. We know that healthcare is very expensive, the equipments are very expensive. What portion do you put into training of personnel towards improving maternal and child health, or just improving health systems in Africa?
For us as professionals, we've created a protection kind of around our own profession to ensure that other people are not gaining these skills, albeit medical officers doing cesarean sections, clinical officers, training midwives, and even having these midwives actually deliver, as Dr. Sharif admitted, that this can be done at home. So what are we going to do as a country in terms of training?
Very well. Dr. Ngatia?
to Phillips, what solutions do you have for emergency obstetric care? Because this is where the rubber meets the road here. And how do we bring it at the level that it is actually needed at the community health facility? That's where those technologies are needed. And again to Dr. Sharif, our expenditure on health remains 6%. What are we going to do? Because we can talk about lack of human resources. We can talk about the needed technology. But again, we need to have the resources that are needed.
Dr. Kihara, the first question was to you from Dr. Wambani of KNH.
Yes.
Do you have guidelines?
We don't have guidelines as far as the devolution of health services is concerned, because a lot of our time has actually been spent in trying to capacity build in training. So that would be probably something we need to consider and think about, generating guidelines for the devolved system.
All right.
The other thing maybe I can marry together is the issue of what Dr. Denya brought up. Why can't we have other cadres of skilled personnel? We have pilot projects that have been done. I'll give one in mention where we train clinical officers to conduct cesarean sections in Machakos, which was pretty successful. But the biggest problem was it still needs facilitation. They cannot be left on their own.
Very well put. And of course there were questions directed to Phillips as well. From Dr. Wambani, we had the issue of training of personnel.
Obviously, training is a very important component. It doesn't make any sense to supply equipment if it is not used to the fullest extent. So that is related to equipment training, which we as a company also provide. To give you an example, we have just installed 60 new ultrasound units in Kenya, the people who have to use the equipment. So that need is fully understood by us, and we are also trying to make our curriculum available to the health workers to be able to conduct safe births. And also in Kenya we are trying to connect to the healthcare society to improve the training and the availability of training.
Very well. And of course, most of the questions were coming to you, Dr. Sharif, because of course you represent government here.
How much do we spend? We spend roughly around 7% of the budget, not the Abuja declaration of 15%, right? But the other issue is, are we spending it in an efficient manner, right? It's not corruption. It's also how we allocate the resources, whether there is allocative efficiency. Are we allocating the money for the right use, for the high impact interventions, or are we just putting it in buildings and which look glorified hospitals, and when you go there, they're called glorified, yet I'm actually admitting it. And you see, every politician likes to see a hospital in his place, right? So a politician goes, he looks at a small facility and says, tomorrow this is a hospital, right? And in reality, it is just a health center. So we're trying to get out of that so that don't pump in resources into this glorified structure. Dr. Gatti asked about whether we shall be...
Dr. Before you move to that,
yeah,
perhaps you can elaborate. Of course, we've had other programs, the CDF, we're building hospitals through the CDF. We've had the economic stimulus program that is employing health workers. So how are you harmonizing all this to make sure that the person at the receiving end, the consumer, is the one who benefits, and we're not having glorified structures, as you put it?
The economic stimulus was one of the ideas of the government, which was excellent. It's still excellent in the sense it targeted 2 MPGs, 4 and 5. The idea was to have a model health center which would provide services for children and women, all right, in every constituency in the country. And at the same time, we would make sure they were equipped and they would have staff. And we managed actually to have around 201 model health centers built in the country. With the CDF, it was a little bit complicated because it was politicians deciding, and the ministries did not know at that time what was happening. But the economic stimulus was a complete package. right? It came with drugs, it came with equipment, it came with ambulances, and we managed to do that. 201 model health centers. I think it was the largest infrastructure project in the ministry for the last 5 years. Coming back to the other issues of allocative efficiency and corruption, you have to make the investments in the right place. So even if you're given 15% and you are spending it on things which are not efficient, right? It's the 16% or 15% will not be enough. Per capita, Kenya spends more on health than other countries which have achieved the MDGs. So we are not spending it in the interventions which are cost effective, or we are putting it in interventions which may be wrong, etc. So I think there's something which we are strictly, sort of looking at. The other issue is that Dr. Ngatia asked me about is, are we going to change our policy? I'm not sure right now, because we are considering whether we'll have traditional birth attendants or whether we will have skilled workers, right, so that they can be delivering. I think the options are that we train staff who have skills on delivery or labor, etc. But the most important thing what we want to do is make sure that those staff whom we train have skills to identify those who are at risk, right? So they have the high-risk signs, and make sure that those ones get referred to a health center or a dispensary or a hospital. I think that is a fundamental issue, and it's a policy change. It will require a lot of resources, but it is going something which will make a difference.
And of course, after the introduction of the community health workers, I don't know if on the ground you felt some change, Lucy?
Yes, I really want to echo what Dr. Sharif has said about training people who will be able to recognize the dangers. Because truly we have a powerful team called the midwives who we don't fully use. Independently, what I do is I go to the home, I see the mom, I am able to advise her one-on-one on what she should do. And sometimes I think, just like Dr. Sharif said, it's a policy change. How about thinking out of that box that is the hospital and sending this midwife out to the community to, talk to moms and identify issues and advise. Sometimes those women just need somebody who will tell them, you know what, you need to come to the clinic tomorrow. Or better still, do the clinic right there where they are. Of course, it will need a lot of change. There's equipment involved, there's time involved, there's accessibility, because even the midwife will need to access the women. But it's a good thing to do, and for me, I have seen it work. So it's one thing that I would encourage the government to do. And of course, as Dr. Pena said, training would be key. So probably look for people who are aware, at least have some medical background, because that at least helps save the situation.
Very well. Now we take a short break now, and when we come back, we talk about the role of each stakeholder in keeping mother and child alive. Stay tuned. We now shift focus to infants. Why are children, 5 out of every 100, not reaching their first birthday? Now, Daktari, what is government doing regarding infant mortality?
Majority of factors are actually related to neonatal conditions, and that's to do with birth and within the first 28 days. So what we are trying to do is address this problem of skilled birth attendants and neonatal care. So that's what we are doing for those under 20, less than 1 month of age. The other ones who die between, let's say, under age 1, right, is we are trying to make sure that we find out what are the causes. And the 3 common causes which used to kill children is first was malaria, the other one was pneumonia, and the other one is diarrhea.
Lucy, of course, when you handle the mother, you no doubt handle the child as well. Yeah. You're releasing this mother from the hospital, and of course you talk to this mother about how to take care of the child. Mm-hmm. What do you tell the mothers?
First, it goes back to quality prenatal care, of which you need to educate the mother way in advance before the baby is here. Because for most mothers, when the baby comes, it's a bit of an overwhelming time. So one of the key things to teach any mother is how to breastfeed. because breastfeeding does for sure take care of a lot of causes for death, especially sepsis. And then of course teach her other principles like taking care of the cord, the umbilical cord once they go home,
the people who
the son. And it's basically how to be a mother, how to prevent death. Like Dr. said earlier, the mother has more concern about their baby being alive than any of us.
And of course we'll bring in Dr. Kihara, who's done a lot of research on maternal health, maternal and child health. How is the uptake of breastfeeding, especially exclusive breastfeeding for mothers in Kenya?
We're asking women to breastfeed exclusively for 6 months, and you find the uptake is only about 32%, which is pretty low. But as my colleague here has said, I think I'll start right from before being pregnant. Does this woman want to be pregnant in the first place? So it begs family planning, having a pregnancy that is wanted. During your prenatal care, what is your nutrition like? Are you having infection prevention, education and measures being put in? What do I think about? PMTCT, HIV prevention strategies. That comes in the antenatal period and extends right through up to your postpartum, which is the 6 weeks after delivery. Things like tetanus, things like malaria. These are things that are preventable or strategies that can be put in place for the mother. Then, antenatal care specifically. You're asking a woman, at bare minimum, come for 4 visits, where we're giving you comprehensive care. I'm assessing the baby and I'm assessing the mother. Because we do have medical ailments and obstetric conditions that can arise. So you're actually having a high sixth sense for detection of problems. Then at the time of delivery, we boil back down to delivery. Where are you conducting this delivery? Therefore, is it safe for the mother? Is it safe for your baby? Immediate newborn attention. Every baby who comes should be able to give a cry, a sign of healthy, bubbly life. What happens for that baby who has developed a problem? Then you get to the postpartum period. In fact, to be honest, mothers carry babies. About 4 million are dying or coming out as stillbirths. That's 4 million. Another 4 million are dying within the first week. More so within the first 24 hours post-delivery. The biggest problem is actually birth-related complications. So in the postpartum period, besides breastfeeding, what of the nutritional needs? What of the contraceptive needs? So it's a continuum. Because you come back again, do you want another baby or do you still want to wait and get it when you really need it?
Save the Children just released a report that showed that it's the leading killer. Pregnancy and childbirth is the leading killer of adolescent girls, that is between the age of 10 and 19 worldwide. A 15-year-old is 5 times more likely to die at childbirth than a woman in her 20s. How are we addressing these issues? How are you, as the obstetricians and gynecologists, how are you addressing these issues?
When we come to contraceptive and mainly planned pregnancies, as we say, when I said or I discussed about maternal mortality, I mean one of the greater components is due to hemorrhage. Another major chunk is actually due to unsafe abortions. And we like it or not, unsafe abortions is still going to kill so many mothers-to-be if we do not implement a law to control that. So eventually that is not a topic that I would want to discuss here because it's a policy-making topic.
Very well, Dr. Of course, abortion, it's very clear in the Constitution that in Kenya it is illegal, except if, in your opinion, as a skilled healthcare professional, the health of the mother or the child is in danger. However, what we can talk about is contraception. Of course, it has a direct impact on, keeping mothers and children alive, for that matter. And Dr. Sharif, I would like to put the question to you. As government, for instance, why do women have to buy contraception? Yet evidence has shown that it is such a basic need that will help keep a mother and a child alive.
What we are trying to do is make sure that women do not buy contraceptives. In fact, the contraceptives which are available in private outlets is actually subsidized by the government of Kenya. So it's not that they'll buy it at a very subsidized rate of around 20 shillings or 40 shillings. But that is a way of making sure that women who do not like to go to a clinic can get it from a chemist. So it's a subsidized network of contraceptives through our social marketing. Right? Having said that, and we have adequate resources. This year's budget, it will be over 1 billion shillings for contraceptives. But the issue is somehow our distribution system tends to get wrong, right? That's one. The other thing is, how do youth access contraceptives? Because we are not youth friendly when it comes to contraceptives, right? Because a nurse is a youth asking for a contraceptive or a chemist, they are more realistic that why is this young woman asking for contraceptives? So we tend to be more realistic. I think we should be moral, but I don't think we should be more realistic to the extent that we do not provide those contraceptives.
Dr. Kihara, you did raise the very important point of women seeking antenatal care, at least 4 visits. And perhaps what is the place, and the statistics are really good on this one from the Kenya Demographic and Health Survey. 92% of Kenyan women get antenatal care from a skilled provider. However, what are the challenges, and do we have adequate technology for antenatal care?
I think antenatal care is really a very basic provision of service in this sense. The Kenya Demographic Health Survey says that 92% at least are going once for the antenatal visit. But what does it entail? Basically, the principal thing, as Dr. Sharif is trying to allude to, is educate, educate, educate. Nutritional education, hygiene education, aspects of breastfeeding, aspects of contraception, detection by the clinician. Is she beginning to develop a problem? In mind, things like, is my baby still alive? It's very basic. Has this woman developed hypertensive disease when you take the blood pressure?
Antenatal care is one of the areas where technology does play a big role. Yes. And perhaps there's a chance for, Phillips to explain to us what options do you have for this? How do we save babies from that early stage when the mother is still expectant?
I believe it is also very important that specifically when you have had a complicated birth, that you continue to monitor mother and child for a certain period after birth. And there are solutions available to be able to do that. Solutions that can measure vital signs and can even including early detection of sepsis. There are protocols available which can be connected to the system which give that early detection. Using these kind of facilities will show immediately when there is a dangerous change in vital signs, and intervention can be done immediately. I also heard breastfeeding. Complications in breastfeeding, also there are solutions. Through, for instance, our Philips Avent product range, you can collect mother milk and still use that milk for breastfeeding through technical solutions. So there are all kinds of solutions available in the market that can help the survival of newborns.
I think the doctors here will concur with me that, breast milk, it's a blessing because unlike cow milk, it doesn't go bad. Now, I would like to bring in our audience now. We have midwives among us. We have, of course, doctors who are the, point of contact with mothers. We also have mothers here to just share with us the experiences out there that, are putting women in danger when they are giving life.
Apart from now sending our community health workers in the community to take on who is bleeding after delivery, we need someone who follows up to see what happens in the village. Those mothers who are hard to reach, what are we doing about it? Because mothers are still dying. We feel so bad when a mother is referred to a facility and there's nothing we can do. The mother is bleeding profusely, complications of blood pressure, eclampsia, and the things we need where we think could have been monitored early from the beginning. So those mothers who are hard to reach, what is the government doing about it?
Next question, please.
What measures are we putting in place to attract and retain these midwives in the rural areas, in the urban areas, in the facilities where we need them most?
My challenge is to the ministry and Philips. In this era of globalization,
there's a lot of teleconferencing. So I'm thinking in terms of to the personnel in the district, I think in Kenya we have a tendency where we always pull the personnel and bring them to the urban areas for training. I'm thinking going forward, why don't we have a system where the personnel are?
My question was directly to Dr. Kiara. It's about awareness. I think when you said about awareness to the mothers. What about the fathers?
We have, I think, 2 university representatives, and I think Aga Khan Hospital and the University of Nairobi need to make significant inroads into training, I think, obstetricians who will then supervise the health workers who will be on the ground. So I'd like to hear, what has been done so far in terms of planning, because task shifting is a short-term goal and is going to solve short-term problems. What is the long-term goal of your training agenda?
All right. A number of questions that were directed to you, Dr. Sharif. Mothers are not empowered. What are you doing about it?
Now, if you look at MDG, its number 1 is reduce poverty, right? Okay, so it's not a question of health people reducing poverty. We have no business reducing poverty, but we have an interest. In the end, it ends up as a health problem. So it's not a health problem, but we end up with those consequences. So the issue is we have to make sure that this multi-sectoral approach is there. Now, we started off with this program, and it's working quite successfully, and it is called output-based approach, right? Where women who have been identified as poor are given a voucher, right? They buy the voucher for about 100 shillings, right? And they can access healthcare at any facility which they like, and then they're reimbursed. The facility is reimbursed, right? Now, unfortunately, the funding wasn't enough, so we have only managed to do it in about 5 districts, and our plan is to make sure that it rolls out to the whole country, right?
Dr. Kihara, and we're still talking about empowerment of women. You are challenged about, what about the fathers?
Yes, in fact, I was very happy with the question that you brought about the fathers. We are a patriarchal society in Kenya. So we have the social-cultural bump, so to speak, that we must address. But that notwithstanding, the Constitution is very nice, because even now they're advocating for responsible parenthood, where they're recognizing there is need to have the father and mother both engaged to bring up children. So I applaud it 100%. Male involvement will actually enhance women's access, if not even facilitate the decision-making that's required for her to seek service.
On the same note, encourage fathers to even be there when their wives are getting the babies. But then we also have to address the male issue, which is men know how to be in control of situations. Now, labor and birth, the process in itself is not friendly where control is concerned. So it's more like orientate the man to what the process is going to be and give him cues on some of the things he can be in control of during the process. But you find that where men are involved, women actually carry the pregnancy even better. They are better mothers. They breastfeed better because the woman tends to feel there's a supervisor to this whole process. While I'm still on it, let me answer the question from Sarah. A very common availability is a mobile phone, which we have ignored. If we can talk to the, mobile facilitators and get a hotline to a clinic nearby and advise a woman, if in case you have any doubts or you have a question, SMS to this mobile number or ask, please call me. Yeah, and you call back the woman to find out what's happening to you and how can we help you.
There was a question regarding teleconferencing, and I would like to put this question to Peter from Philips. What's your comment on that? Using teleconferencing for training, not just for the healthcare workers, but also for mothers.
Teleconferencing, obviously, universities in Kenya also have on their own option. They can take the initiative to reach out to universities elsewhere in the world. And as Philips, we can mediate if that is a requirement. But some initiative, self-starting initiative, to engage with other members of the community outside Kenya would, I think, also be a good start to make these kind of things possible. So, again, facilities are there, also within Philips. The big question is how to bring it to the people that really require it.
How do they bring this technology to the people, Dr. Sharif?
We've actually worked with some of these programs. We are trying it out. And the other one is telemedicine. And we are in discussions with several organizations. Because for telemedicine, you need a little bit more of infrastructure. But e-learning is not really that much. So, and it is, I think, now a learning requirement for all health professionals that they must have CPD, continuous professional development, of at least 40 hours in a year.
All right, so beyond training them, there was a question about what measures you're taking to attract and retain midwives, and I believe that this is something that also, cuts across the medical healthcare professionals. It is not just the midwives. You also need doctors. We need the specialists, the obstetricians and gynecologists.
It's easy to get somebody to work in an urban area, but to get them out in the extreme hardship area, and the government introduced the a hardship allowance and extraneous allowance based on where they work. Let's see if that works, because if you are in extreme hardship area, you get more allowances. So that's been implemented in January this year.
Very well. It sounds like we're already having solutions here. So just as we wind up, I would like our panelists to just give us 2 or 3 points, way forward. What can be done to meet the 4th and the 5th Millennium Development Goals? How can we have the deaths of these mothers, these babies, and if possible, how can we eradicate them in this country? Dr. Ann Kihara, we can start.
I think I'll start from data. We have a lot of data, but are we utilizing the data to improve our services? It begs for clinical audit, it begs for monitoring and evaluation, it begs even for more research in this regard. We're talking about accelerating MDG 4 and 5 by 2015. I don't think this can happen without integrating the various disciplines. Ministry of Health as a backbone, the Kenya Obstetrics and Gynae Society, the universities, the Kenya Pediatric Society. We have to have integrated multidisciplinary approach. Leadership is the other issue. And that also begs leadership from political goodwill. Without that, we will never get anywhere.
Very well. And of course, Peter, you've shown a lot of passion in, dealing with issues of maternal and child health at Philips. And for that reason, we're having this forum. What can you propose as the way forward from the discussion that we have had here this day?
We are really passionate about healthcare. I've heard several times, can Philips do something about the price of the equipment to make it affordable to us? And actually, I would like to make a little challenge on equipment being expensive. The majority of the money spent is actually on staffing and on pharmaceuticals in a healthcare infrastructure. Next to that, what is the cost of equipment? The cost of equipment is not only the purchase price of the initial piece of equipment. It is also the total running cost. And for instance, the device that I talked to you about earlier that we have now brought to Kenya is, for instance, 60% energy saving compared to previous devices. In the running of that equipment, that is a cost saving that is never calculated when people are talking about the purchase price of equipment. I believe that as industry and healthcare providers, governments, we should get much more even engaged and work together and discuss what are the requirements, and also be able then to provide the equipment that is really geared to the requirements, the clinical requirements of a specific country. I believe that the tools are there, the equipment is there. We need to find a way to make it possible to make that equipment available to the complete country, including the rural areas, and also there with healthcare IT, infrastructural solutions. It is possible to bring care also to the rural areas and to make the facilities available there as well.
Very well put. Lucy, of course, this is something that, as a midwife, there's so much you can say how you can help a mother and a child to survive. But just 2 or 3 points that mothers and children are kept alive.
Okay. First, birth in itself is a family-oriented affair. I think it's time that we went back to what we were doing before, but in this case, do it different. Have a skilled personnel attending the birth, but have and enable the skilled personnel to be able to refer in case there's an issue. And then, of course, we need to look at the simple resources we have. I am a bit passionate about TBAs. They do very good stuff, some of them, and they're skilled. It's probably look at them in a different way, see what can we empower them to do and how can we supervise what they're doing, as opposed to just, wiping them out. But if we have people in the community who are trusted, because these TBAs are really trusted by the women in the community, what we can do is look for ways to empower them.
Dr. Yamal.
Let's have more education of the public on these facilities, on the antenatal care, on the birthing process, and on the fact that, yes, they do need to go and have some skilled assistance, at least during some time of the course of the pregnancy. There is nothing wrong with deliveries at home if we have the right supervision there, and if we have the right people to supervise that and who know when to refer or when to now know that this is a point where I need an expert opinion now. And finally, preventive is definitely better than curative. So we need to now get into the fact that we need to know which pregnancies are heading towards disaster. It's not that difficult to pick out the pregnancies that are heading towards a disaster. And if you pick them up earlier, you will prevent the disaster.
Well, Dr. Sharif, today you are taking all the heat on behalf of government. We are always asking tunaomba serikali. So just your closing remarks.
Let's look at it from a positive point of view, right? If you look at under 5 mortality, it has reduced, right? And if we just accelerate a little bit, I think we'll be on target in terms of getting to the MDG target for 2015. All we have to do is tackle 2 things on... We've had tremendous success in malaria. We have had tremendous success in reducing admissions due to malaria and deaths. Now, the common cause of deaths now, as I said, was diarrhea and pneumonia. So if we just manage to make sure that no child dies of diarrheal diseases or pneumonia. We got the pneumococcal vaccine last year, and so we hope it will reduce. We're planning to introduce the rotavirus vaccine next year. That will make a difference in deaths. But the thing is, we also have to make sure that people know how to get ORS solutions and zinc, because that's something which it's easy to go make available. For maternal health, it may be a little bit slow, right? But coming back to what I said about making progress in reducing under 5 mortality. See, the issue is progress is not success, right? So maybe progress. In the end, we'll just be measured, are we successful or not? Nobody looks at progress. How do you monitor progress? You train this person, you got this. It's not, you have to be successful. So you don't have a challenge, you have a job to keep, right? And I'll be measured on getting MDGs by 2015. So the thing is, I cannot explain that, I'm making progress. It is success. And we want to go for success in terms of both the reducing child mortality and maternal mortality.
And on that point, we have come to the end of Saving Mother and Child. We would like to thank all our panelists for participating. You have kept the debate alive, and I believe that we have come up with very important points that can direct the way forward. Thank you very much for making this a success. And to our audience, thank you very much for participating. And to the audience at home, thank you for being part of Saving Mother and Child. Until next time, my name is Ansel Mwendia.